the current era when antibiotics are mostly effective could disappear. It's possible that our children or our children's children will look back in 2050 or 2080 and say, goodness me, the period from 1930 to 2030 was a golden age when we actually had effective treatments against common infections. Now, I hope that won't happen, but that's the kind of scenario that we're looking at.
Palm Catholic Hospital in Ghana is like many district hospitals across the developing world. Serving more than 200,000 people with 105 inpatient beds, it doubles up as a primary care facility. Hundreds of people come every day to its outpatient department. Halifa is a nurse in this busy part of the hospital, but recently she's had health problems of her own.
I started feeling having headache, stomach ache, feeling feverish. Then when it's in the evening, I feel cold. So first I thought it was malaria. I took malaria treatment, but still. So I reported to the hospital, and then they asked me to go for lab. They told me I have typhoid.
Palm has a critical shortage of drinking water and extremely poor sanitation. Typhoid, cholera, and other diarrheal diseases are endemic, and Halifa's treatment is proving difficult.
They gave me Cipro. I felt a little bit relief for some times, but then 2-3 months later, I felt the same thing. And then when I went for the lab, it went higher than the first one. So they gave me Cipro again. In fact, to cut it short, I have taken Cipro for about, let's say, 5 times.
Halifa's drugs aren't working. Her typhoid infection seems to be drug-resistant, and she's not alone. Typhoid-resistant to ciprofloxacin and other antibiotics is found across Africa, Asia, and South America. Chloroquine-resistant malaria, which first emerged in Southeast Asia in the 1950s, now plagues all the world's malarial zones. And extensively drug-resistant tuberculosis, which is virtually untreatable, has been confirmed in at least 58 countries. In the poorest countries of the world, where infectious diseases are prevalent, drug resistance is on the rise. Weak health systems cannot cope, and patients suffer as a result. Children are often the worst affected when drugs stop working.
Children are more likely to die rather quickly if they have a systemic bacterial infection like bacteremia or typhoid fever. And so there isn't the opportunity to get it wrong and then use something else the second time around. These are very deadly diseases, and with children you have the added concern that even if they recover, there's a chance that there'll be long-term damage.
The impact of drug resistance is also felt economically. In Ghana, losing ciprofloxacin as a typhoid treatment is costly.
If you compare the cost of treatment, for ciprofloxacin, the cost will cost about 3 Ghana cedis, close to $3. But you look at azithromycin, the cost for treatment of a 7-day course of the drug, that is around 11 Ghana cedi. Just one vial of ceftriaxone costs around $7. So for a 7-day course, you can just sum it up. That's the cost of resistance.
The development of drug resistance is somewhat inevitable. As a disease pathogen is exposed to a drug, it mutates in response or relies on pre-existing mutations that give it a better chance of survival. Some bacteria can destroy the drug or pump it out before it has a chance to take effect. Bacteria can even pass resistance-conferring genes across species. Over time, drug-resistant strains dominate. But humans speed the process. Penicillin was identified in the 1800s and formally discovered by Alexander Fleming in 1928, but it wasn't mass-produced until 1944. Greeted with huge excitement, it was widely used, not always appropriately. Within just 2 years, infections resistant to penicillin were seen, as Fleming himself had predicted. Since then, this scenario has played out again and again. We spend time and money developing drugs, then overuse or misuse them. Many lose efficacy within a few years or even months. But in developing countries, this is rarely monitored, and drug-resistant disease may affect many people before it's recognized. In an epidemic such as a cholera outbreak, this can be disastrous.
There was a very, very large epidemic in Goma in 1994, right after the Rwandan genocide in a refugee camp. This was a case of a cholera epidemic and a concomitant dysentery epidemic. Both the bacteria were resistant to naldixic acid, and this was the drug that was chosen for empiric therapy. It's quite probable that using that drug led to a very large epidemic. It's not very easy to test for drug susceptibility in some infections, for example HIV and malaria, but for many bacterial infections, it's a very simple and inexpensive protocol. You spread the bacteria on a plate, add a disc of antibiotics, and you can determine which bacteria are present and which antimicrobials they're susceptible to. If you know the resistance pattern in an area, you can predict which antimicrobials might be most useful.
Knowledge about drug resistance is the foundation of being able to act against drug resistance. We have hospitals, district labs, and national and regional labs, and they need to be communicating with each other so that we can see where resistance is occurring and how it's spreading across geographic regions.
In Khalifa's case, it was the hospital pharmacy that noticed her treatment failure and identified a new drug.
The doctor wrote Cipro for me, but when I went to the pharmacist, he told me that he has noticed that I've been taking Cipro for a while. I'm not getting better. So he changed the drug to azithromycin. So yesterday, I went for the lab again, and then it's almost the same thing.
Khalifa's not getting better. Her typhoid infection may be resistant to azithromycin too. Additional diagnostic and drug susceptibility tests would help her get the right drugs, but she can't get those tests done locally.
We take the samples and send them to Nogochi. That is in Accra. That is the only option that we have. We cannot do that test here. We need a new structure altogether, and we need a new equipment. When those things are in place, we'll be very happy to start doing the susceptibility test. So the clinician can know what drug to give and how to monitor the patient to take the drug.
Building laboratory capacity is therefore critical. Khalifa did get an initial laboratory diagnosis. This is a vital step most patients can't or don't take, increasing the risk they'll use unnecessary or ineffective medicines. Patients may self-diagnose, particularly with an embarrassing condition, such as a sexually transmitted disease.
The first thing they talk about is ambient ampicillin. So you sit the person down and find out why, and then you realize it's an STD.
Patients may also stop taking their drugs, particularly if side effects are unpleasant.
The first time I started taking Cipro, I felt very, very ache in my abdomen. So I complained, and they told me it's one of the side effects of the Cipro. So I continued taking it. But sometimes when I start taking it, it's hard for me to even finish it.
Influencing patient behavior is hard, but dispensers can help. In Ghana, informal drug sellers are trained to tackle drug-resistant malaria.
You know, chloroquine was a very good anti-malaria product, but now because of the resistance, we are facing it out.
They organize courses for us, train us on how to present the drugs and then how to dispose of the drugs, how to receive our clients.
Reaching out to dispensers through training, accreditation schemes and professional associations is vital. Dispensers must be informed about proper drug use and the prevention and impact of drug resistance, as patients often go to them first for medicines and advice. However,